So, hello everyone, and welcome to a new webinar from a series hosted by Fanta Dental. Before starting, I would like to thank Fanta Dental for the invitation. And today webinar will be focusing on shaping procedure, and I will introduce to you the rising system, where you can see how we can play with a sequence to manage different clinical scenarios. So before starting talking about shaping, I would like to share with you this case. This is a patient who was referred to me with a separated file in the mesobuccal root of maxillary second molar, with also a perforation in the floor. So here's the situation preoperative. Here you can see we have a perforation in the floor of the bulb chamber. And we need to manage the separated file in the mesobuccal canal. Access modification and pre-flaring to the mesobuccal canal. Here I used the Gates Glidden, size 3 and size 2. And with ultrasonic, I'm getting a straight line access to the separated file. And now clearly we can see the separated file. With ultrasonic, I'm starting to do some troughing on the inner wall of the curve, that side toward the furcation, and here we need to take care not to do over reduction. Then we need to flush to remove away all the debris that's forming because of cutting. Drying, and here it is well seen. The full cross section of the file is seen now. I'm continuing troughing. Now it's the retrieval phase. So after a little bit of troughing, all I need is to put some irrigant or activate the coolant so the file can come out. Exploring the file using DG16 probe. And here I am activating the irrigant with coolant open, so we can have the file out. It's not that easy procedure. It's a little bit difficult. After removing the file, we need to manage the perforation on the floor. So I will start by obturating the canal. And before obturation, I need to protect the perforation site using a sterile Teflon. So I'm trying to pack it into perforation site. Now I need to make sure that I have good accessibility to the canals for obturation. Mesobuccal, as you can see, the floor was badly manipulated. Now I'm injecting my bioceramic sealer in the mesobuccal canal, distobuccal canal. You need to take care during the injection of bioceramic not to pass beyond the apex or to push the material beyond the apex. Here is the palatal. Introducing the mesobuccal master cone getaperca. Down packing using the e-heater. Distobuccal. Down packing. Compaction. Now in the palatal canal, same steps. Insertion of master cone. Down packing. After compaction, we need to backfill the canal. And here's the situation after obturation. Now it's time to remove the Teflon tape, the sterile Teflon tape, which was in perforation site to start to seal the perforation. We're backfilling all the canal, then we'll remove the Teflon tape. It's not an easy case, and it needs or it requires too much of precaution to be done perfectly. Now, perforation is ready to be repaired. Using putty ceramic material, I can adapt the putty ceramic to the perforation site using the pack of paper point for gentle adaptation and to absorb also excess moisture if present. Adaptation using the pack of paper point. And here's the situation after finalizing the treatment. And this is a post-operative radiograph. It's not an easy situation. It's not an easy case to manage. But why I start by this case, however, my lecture is about shaping. Actually, because I want to show you how difficult sometimes is retreatment. Retreatment is not that easy part of endodontics. Sometimes we need to deal with difficulties like broken files, like perforations, sometimes with transportation. So we have a hidden cost of endodontic retreatment. It is not only about the money that the patient's paying, but we have also some hidden cost, starting by the biological cost. You need to understand that what you are removing from the tooth is not reversible. It's irreversible. So to gain access to the canal and to shape it and to clean and to make some debridement, you need to remove more tooth structure, and this is irreversible. Also, prognosis is not like primary treatment, and time for sure is not like primary treatment. Sometimes we need like 2 or 3 visits, more time to manage retreatment case. So when we talk about the tooth structure, in retreatment, we sacrifice more tooth structure because we remove additional dentine to gain access to the canals. Then we need to remove the filling material, bypass procedural errors like ledges, broken files. So every millimeter of dentine removed during retreatment is an irreversible. So that will come on expense of the mechanical objective of our endodontic treatment. And regarding prognosis, here is a study, a study done by YL and G, V-Man, and Gulabievla et al. So in this study, they were comparing prognosis of both primary treatment and endodontic retreatment. And for sure, the prognosis of retreatment is lower in long-term predictability than primary treatment, even in skilled hands, and it's very important. So even if you did the treatment properly, still retreatment carries lower long-term predictability and for sure lower prognosis. And when it comes to time investing in retreatment, we have longer time for gutta perca removal, for error correction, and also it might need multiple appointments. So these are like hidden costs in retreatment. So the conclusion, the economics of prevention versus correction. So regarding the prognosis, we have 6% lower in prognosis in retreatment than primary treatment. Time, 2 or 3 times more for the treatment, and 100% dentine loss. What we mean by 100% dentine loss, it means what we lost during retreatment for access to the canals and for managing the mishaps is irreversible. So why not to make it right from the start? Why not to make our treatment right from the start? No need to go for retreatment. If we did it well from the first attempt, for sure, no need to retreat the case. So we need to answer this question. And to answer this question, we know that shaping step, or the part where we are using the file, is the part of treatment that has most or more or many errors that could happen during shaping, like ledges, inability to maintain the original canal anatomy, perforations, broken files, transportation, and blockage. So we need to take care during this step to ensure that our primary treatment will be predictable and successful. So during the mechanical part of the treatment, we need to allow sufficient irrigation to reach to the apex, and also to allow easy obturation and 3D sealing to root canal system. This is the objectives of mechanical part of the treatment. During shaping, we need to maintain sight and integrity of the apical foramen, not to transport the canal. And also we need to preserve as much as sounds to structure for long-term mechanical success and for longevity of the treatment. So simply, we need to prepare the canal in the shape of continuous tapering, transform the canal from the slim shape into continuous tapered shape for more efficient irrigation delivery to the apex, and also to facilitate obturation. We know that during shaping, crown down is the gold standard technique. It's more safe and also less bacterial accumulation at the apex, because we prepare first the coronal portion, followed by the middle, then the apical. So the bacterial load at the apex will be less. Also, stresses on our files will be less, going to larger sizes preparing at the apex. So here's a sequence we should follow during shaping the canal. Starting by pre-flaring, and usually we do pre-flaring using orifice opener or pre-flaring file that will decrease coronal interferences. That should be followed by glide path, manual and mechanical. This is my preferred way. Start by manual, followed by mechanical, to ensure a safe path to the apex with the larger size file. Then starting by body shaping, or we call it mid-root shaping, that will make our irrigation more efficient in delivery or for delivery towards the apex. Then start by apical finishing. What we mean by apical finishing is more apical debridement to ensure that our apical size is enough for irrigation penetration and irrigation delivery. In this case, I'm showing you with a simple sequence, starting by pre-flaring, glide path, body shaping, and apical finishing. We were able to reach safely to the forking length, ensure a good quality of treatment. Here I'm showing you that sometimes we need to end our preparation to a small sized file, not like usual 2506 or 3004, because of the risk of doing some errors like ledges or file separation. So sometimes we need to end our preparation at smaller size, maybe 2004. So many dentists would think that in managing difficult cases like this, files are the magic wand, or files only can solve the difficult part of the management in case like this. However, situation is different, and I'll show you now how to think during management or during shaping of cases like this. This is a case that I've treated a long time before, and if you look here, you can see that I used different types of file. That was in the era of profile and ProTaper from Dentsply. So usually I start my treatment in the past using ProTaper. It has high cutting efficiency, and also it is a rigid file. So it has good penetration ability in first phase of shaping. And going into final phase of shaping, I'm shifting to profile because it is more safe. It's preparing the canal more by scrapping rather than actual cutting. So they have two different cross section, and each cross section has its own advantage. So I can get advantage of special cross section of the ProTaper in the first or the start of shaping phase. Then when it comes to the end of shaping, I can shift to a less invasive file, maybe more flexible, that can safely shape the apical part of the canal. This way, with a hybridization using two systems or two files from different systems, I can safely shape the canal. That would let me talk about the hybridization that I think in the past was a very important part of endodontist practice. So we used to hybridize, means take different files from different systems to get advantage of each one in specific situation. This design of the file, I did it long time before, showing that if we can have a file with a different cross section, so each part of the file can behave different than the other in a specific part of the canal, but for sure it is not valid or it is not present now. So I will introduce to you now the rising system, and I'll show you how using rising, we were able to solve many problems, especially in hands of beginners who are facing difficulties during their first trials to treat endodontic cases or difficult anatomy. Rising, I call it a biological enabler and beyond mechanical solution. Why I'm calling it beyond the mechanical solution? Because all of us knows the pericervical dentine. The pericervical dentine is a part of the tooth structure, which is adjacent to cristal bone, 4 millimeter coronal and 4 millimeter apical. This is as defined by David Clark and Khadimi in 2010. And this part of the tooth is very important in terms of resistance to fracture and longevity of the tooth. So we need to maintain the tooth thick as much as possible at this part so we can ensure longer time in patient mouth. And during shaping, our files need to respect the coronal part during pre-flaring, and also during radicular preparation, we need to maintain tooth structure as much as possible. And for the apical portion, we need also to not over enlarge the canal, not to initiate a vertical root fracture. So this we call it the conservative preparation. And with rising, actually we have conservative preparation and we can maintain the pericervical dentine thickness or thick part of the tooth, thanks to the special cross sections that I will discuss with you now. We have, like, it is not an aggressive taper, it's a constant taper, but actually with rising, we have preserve to pericervical dentine and preserve also to structure. And I will show you now some cases that prove what I'm informing you. Here is a sequence of the rising, starting by pre-flaring file 18010, we call it RR, followed by R1, which is 1303, and this size is like magic in mechanical glide path, followed by 2504, 2805, 3004. 3004 is the R3, and 2805 is the R4, and I'll describe to you now the importance of each file in each specific situation. Starting by the coronal shaper or the orifice opener or pre-flaring file 18010, actually we use this file to enlarge the coronal portion of the canal. By pre-flaring, we enhance tactile sensation at the apical constriction, so we can have better or more accurate working lens determination, also decreasing two stresses on the files that would shape the mid portion of the canal and the apical part. So pre-flaring is very important to reduce incidence of ledge formation, canal straightening, apical perforation, and instrument separation or broken file, stripping to the canal and the apical blockage. Here are some studies that prove that pre-flaring would enhance or make working lens determination more accurate, and also reaching to the apical constriction. So some would say that we need to avoid the pre-flaring step in terms of, or in order to preserve the pericervical dentine. For sure, we need to take care during this step not to remove too much of dentine at this part of the canal, which we know that it's very important. But I can say that pre-flaring is a must for beginners, especially for beginners. We need to enlarge the canal for sufficient size that would decrease stresses on the files that work in middle and apical portion of the canal. So it could be a must in hands of beginners or in difficult cases. Sometimes we do it also in difficult cases. And it should be avoided in straight white canals and immature teeth. And in immature teeth with open apices, it should be avoided. No need at all to do pre-flaring. It's an optional step in hands of experts. As experts, we knows when we can skip a pre-flaring step and when it is a must to do. But I would recommend pre-flaring step for beginner for safer preparation. That should be followed by the manual glide path. Manual glide path, as defined by John West, as a smooth reticular tunnel from canal orifice to physiologic terminus. And to make sure that we have glide path, and it is a safety cornerstone for mechanical preparation, we need to have size 10 K file super loose inside the canal. Cliff Rodell stated that whoever owns the glide path wins the shaping game of endodontics, because any error that could happen after glide path correction would be easy. However, if you have an error happen before glide path or having the canal patent from the orifice to the foramen, actually correction would be too difficult. I would say that many endodontists skip the manual glide path using the manual file, and they can go directly for mechanical glide path. But actually, in some cases, I can see it's a must. The manual glide path is a must for safer preparation and also to ensure a smooth path towards the apex, especially in cases like this with severe curvature, with multilateral curvature. I would recommend the manual glide path before going into rotary. So we can have this kind of shapes, beautiful shapes for sure. And I know that all of us would appreciate treatment quality like this in terms of shaping and maintaining the canal anatomy. One important point I would like to highlight, especially because I'm involved in training programs in some universities, in some courses. So clinicians or candidates in their first trials, they don't care about the size of gloves. However, I would recommend, or to prove, that tight gloves would enhance better the tactile sensation. So please try to wear smaller size than your actual size, so it will enhance your tactile sensation. And also try to minimize the contact with the file, because in endo, we don't need force. We don't need to push. So if you hold completely the head of the file, maybe you put some force with uncontrolled. However, with minimal skin contact or minimal gloves contact, you will have that gentle touch. Even if you're pushing, you will have a gentle push, which is also safe on the canal walls. And during manual glide path, we don't need to forget that we need to recurve our manual file before introducing inside the canal. This is for a safer preparation. After the manual glide path, we followed by the mechanical glide path file. In our case, it's 1303. This file bridges the gap between the manual instrumentation and the following shaping file. We call it transitional file. And in our case with rising, our file is 1303. It's a rising R1, we call it rising R1, and something extraordinary start to appear here is a variable cross section. We have variable cross section with a R1. So as I informed you, with a variable cross section, we can take advantage of a specific cross section of the file in specific parts of the canal. So before I showed you that we need to hybridize and to use some files in a specific phase of shaping. However, now we can, in the same file, we can have variable cross section, so we can take advantage of each one in a specific part of the canal. Going to the R2, still also 2504, from D0 to D16, we have also a variable cross section. Sorry, I can't share it with you because it's a patent. Once it's possible to share it, for sure the company will share it with us. And here is a R3 3004, also with a variable cross-section. 2805, variable cross-section also, and this file is very nice. Sometimes after completing shaping difficult canals with R3 3004, if we try to introduce our Gutenberg cones, it's not going easily because of the friction of the canal. If we use the 2805, it would facilitate the insertion of the master cone Gutenberg into the canal. So this file is very nice, and I'll show you now some sequences that we can modify to manage different clinical scenarios. We all know that we have constant taper and variable taper. Our files are constant taper. In my opinion, variable taper are nicer, but with our system, constant taper with a special cross-section and variable cross-section shows also good behavior during shaping inside the canal or during acting inside the canal. So for me, it's very, very nice to have a file with constant taper and variable cross-section, special cross-section. That's a very, very special cross-section. You need to give it a try to feel the properties of the file. So with a constant taper and special cross-section, we have conservative reparation, as we discussed before, prevent undesired canal enlargement, regardless of an instrumentation extent or duration. So even if you're using your file many times inside the canal, it will not enlarge the canal more than the size of the file. One last point about the rising, that also in rising, we have hybrid heat treatment. We know by heat treatment during manufacture, we can control the properties of our files from being stiff into more flexible, from cutting efficiency, high cutting efficiency into less cutting efficiency. So we can have different files with different behavior inside the canal. And it's the same that we have here also in rising. With Fanta, we have different thermal treatment to nickel titanium, starting by the AFL, which is slightly martensitic. It is not the traditional light tie. We know that traditional light tie is more stiff. Cutting efficiency is very high. AFL is slightly martensitic. That means it is more flexible than traditional nickel titanium. Going into AFR and AFH, which is more flexible, and it can manage different or difficult cases, difficult curvatures. So with our files, when we start shaping or when we talk about the RR and the R1, they are more stiff because in initial phase of shaping, we need like quite rigid files to be able to penetrate inside the canal. Going to the last files, we need it more flexible to manage the difficult part of the canal without causing any errors. So we have hybrid heat treatment also with rising. So with rising, we have hybrid heat treatment, variable cross-section, and also preserving to the root canal structure. I know that some would say, doctor, please give us a sequence so we can use in different clinical scenarios. And here also we have a recipe. While I don't like recipes because it's a more clinical judgment, but it could be also a guide for beginners, what to use or what to follow in sequence. So for easy canals, we can start by the RR, orifice opener, followed by the manual glide path. And because it's already an easy canal, we can go directly to 2504, followed by the R4. And I want to tell you that rising has its own special Gutenberg. You need to use it for a perfect master cone fit. For medium canal, you can use the R2 as your final shaping file. And before it, you can use that one, the R1, which is a mechanical glide path. Moderate canals, this is a sequence. You can take screenshots. And for sure, I'm sure that this presentation will be recorded, so you can review it also after that. Here is a sequence for moderate canals. And this is for hard cases. As you can see, for hard cases or severe curvature, we use the full sequence. And here's for extremely difficult cases. As I told you, the master cone fit is a very important step during obturation. Actually, it's the step where most obturation errors would happen. So we need to take care. We need to have a true tuck back. That means that our master cone is fitted more at the apical part of the canal. So we have a good resistance for, and also good seal at the apical part of the canal. What I really noticed with the master cones is the precision. Master cones of rising is very accurate, matching exactly or more precisely the files. So if you're using the R2 or R3 and you're using its own Guttapercha, you'll get perfect fit of the master cone inside the canal. However, this is the rising Guttapercha of the Guttapercha of rising. However, each clinician should master the art of cone fit. Sometimes you need to modify your master cone, and it's very important. As I told you, selection of the master cone is very important to safely or to secure your seal so you can avoid errors that could happen during obturation phase. Now I'm showing you the sequence on this severely curved lower molar using the rising. So here is our kit. You need to scan the QR code so you can make sure your product is authentic or original, not a copy. So starting by pre-flaring, after irrigation, we need to do a little bit of brushing in the coronal portion onto the outer wall. Now we can see that our needle can penetrate deeper in the canal. This should be followed by the manual glide path in watch winding motion. Don't push. Once your file reach to the estimated length, you can do like filing motion up and down, or push pull. So your file will be super loose. So it is safe for the further file or the files that would be used after that. Then we need to irrigate. Mechanical glide path using 1303. I love this file. Coronally, no resistance. The file is easily following toward the apex. Irrigation. (2504). In this case, we are using 2504 for body shaping. It is not the final shaping file. Irrigate. Then we need to use size 10K file again for recapitulation and to make sure that we don't have any blockage at the apical part and our canal is patent. You need to irrigate. 3004. Once reach to the apex, just 2-3 strokes and it's enough. And here's the 2805. Sometimes we can use it after the R3 or before, based on the sequence that I shared already with you. Now we need to check the tuck back and the fit of the master cone. Here is R3 master cone Guttapercha and 2 mesial canals. And as you can see, it's going to the full length, and here is the distal canal. For sure, all canals shaped using rising system. And here is the master cone in our model. Then I'll show you the system in action in a clinical case. where we have here a tight mesial canals, tight distal canal also, because we have some calcification on the coronal part. So I'm starting by pre-flaring the canal using the RR. A little bit of brushing. This is a very nice case. I'll show you all the properties of the file in this case. Using ultrasonic, I'm cleaning the isthmus. So I'm sure that there's no tissue there, and also there's no extra middle mesial canal. Here is our one, mechanical glide path. In this case, I'm using the iRoot Pro from Fanta Dental. It's a very nice endomotor, where I'm using on the OTR. OTR is a safety feature present in the motor to avoid file separation, especially in tight canal like this. So the file is rotating. Once torque increase or the load increase on the file would shift, or the motion of the motor would shift into reciprocation. Now the body shaping using GR2. Followed by DR3, 3004. Irrigate, and as you can see, our needle can penetrate very well. Now with the Actor Eye Pro, I'm ultrasonic activating my irrigation inside the canal for better cleaning, better debridement. Now canals and our system is clean and ready for obturation. We have confluent mesial canals, so we can see that bioceramic sealer is coming from the other mesial canals. And here is a master cone radiograph. Now distal canals are also a confluent, and here you can see how conservative is our preparation. I'll show you again the post-operative radiograph. Here you can see it. Okay, it's a very, very conservative preparation. Thanks to the variable cross-section, we maintained the multilinear curvature of the canal with very and highly conservative preparation. You feel like our files has a regressive taper, but thanks to the variable cross-section, variable special cross-section that would enable preserving to the root canal structure. Here's our last case. It's a case of retreatment, which was referred to me because the dentist was not able to locate one of distal canals. So here I'm trying to locate the canal using ultrasonic under magnification. Here our guide is the color difference or the dark areas in the floor of the bulb chamber that would guide me to the site of the canal. And here I went directly using the R1 1303 because it has some austenitic feature. Yeah, it's a heat-treated file, but it has some austenitic feature. So it has the ability to penetrate in first phase of shaping. So as you can see here, our file is penetrating very well. For sure, you need to put irrigant during this step. I am pre-flaring the canal using the RR. But I want you to pay attention here. I'm pre-flaring also the mesial canals, but something strange would be noticed now. After pre-flaring to the mesial canals in brushing motion, we can feel the cutting efficiency of the file. For sure, we need to put more irrigation. But for experts, we know how to overcome the less irrigant in the canal. So it acts like a saw cutting inside the canal. So it will enhance accessibility to the apical portion of the canal. Here, if you look, the two distal canals is not or are not centralized with the two mesial canals. So in my opinion, I would go searching for fifth canal. Using ultrasonic in that dark part of the canal, of the bulb chamber, I start to do some troughing, trying to expose the canal if it is present, opening the column to flush away debris. And yes, here we can see that we have another distal canal, distal buccal canal. So what we found before was a middle distal canal. Again, with a R1, because for tight canals, I will not prefer to go with an orifice opener. First, I will go with a mechanical glide path file, then I start my conventional shaping sequence. Here we have 3 canals in the distal part or the distal root. And because we have limited mouth opening here with a long root, thanks to the pre-bendability of the files, because they are heat treated, we can enhance the accessibility to our canals in limited mouth opening patients and cases where we have our teeth more distal. We can pre-curve, so we can get advantage of the pre-bendability of the file. Here we can reach to the forwarding length using the R2, and here's the R3. It's clear that we have variable cross section on this system. Here is the distal canals. And now we are using the R4 2805. Then sonic activation, because we have here a curved canal, so ultrasonic should be limited to the straight portion of the canal. However, at the area below the curve, we need to use sonic activation because it's flexible and more safe. Now obturation using bioceramics. We can appreciate here the complexity of the system. So all 3 distal canals are confluent. Same also for the mesial canals. You need to take care during injection of bioceramic inside the canal. It should be passive, and the nozzle tip also should be free inside the canal, not to push the material beyond the apex. And here's the case after obturation. Rising system behave very well, maintaining also conservative preparation, in this case with severely curved roots. So that was the end of my presentation. I shared with you today how we can use the rising system in different clinical scenarios. I showed you also the sequence in different clinical cases, starting by the easy, moderate, going to severely curved canals and very difficult canals. You need to give it a try. I'm using the system for more than 10 months now, and I can say that it's a great system, thanks to Fanta Dental for introducing great products to us. At the end, I'd like to thank you all for being here. I'd like to thank again Fanta Dental for the invitation, and see you again in another webinar soon. Bye-bye.